Welcome to this educational activity where Dr. Sloan Manning offers insights on the management of major depressive disorder. After completing the activity, access the post-test and evaluation form by clicking the red Get Certificate button. We encourage you to download the slides, practice aids, and any other activity features that may interest you.
Hello, I'm Dr. Sloan Manning. I'm from the University of North Carolina at Chapel Hill, and I co-direct the Mood Disorder Clinic at the Family Medicine Residency Program in Greensboro, North Carolina. Today I want to share with you a story about a patient of mine who has major depressive disorder, and I think we can all relate to having a patient who really resonated with us in our care of patients with depression, and one of those patients for me was Ginny. She's 39 years old, a certified public accountant. She has two adolescent girls, one 14, one 12, both born by C-section. Ginny is just one of the 15 million people in the United States who suffers from this mood disorder. Major depressive disorder is thought to be the result of dynamic interactions between early and late life adversity and some complex epistatic and epigenetic factors. It's a clinically heterogeneous condition, and unfortunately, current nomenclature doesn't allow us to choose specific treatment strategies for the various particular subtypes that we think exist or may be identified in the future based on genetic testing. Mood disorders are pervasive and associated with changes in endocrine function, autonomic function, immune function. Remission and functional recovery are the optimal outcomes in the treatment of major depressive disorder. And I want to take you through Ginny's journey through treatment of major depression, beginning with her initial episode and into the episode during which I was treating her. So she presented to her family doctor at about age 29 during this depression during her divorce, complaining about fatigue and difficulties concentrating, but if you ask a little bit underneath her chief complaint of fatigue and difficulty concentrating, there was sadness, there was sleep difficulties, there was a feeling that nothing made her happy, that she couldn't see a purpose in life. She was feeling guilty about herself, the way she was raising her children. It was a pretty bad time for her. So based on Ginny's symptoms, her family physician diagnosed her with major depressive disorder based on the DSM-4 criteria. The DSM-5 was introduced in 2013, but the core criteria for major depression really didn't change from the criteria for major depression in the DSM-4 There were a couple of things, though, in the DSM-5 that are worth noting. First, there is a type of major depressive disorder called with mixed features that was added to acknowledge that some patients have the coexistence of manic symptomatology, up to 3 symptoms, along with their major depressive episode. And second, the bereavement exclusion was omitted to acknowledge that major depression in the context of normal grief could be severe and was recognized as a complication of grief, and grief itself could precipitate a major depressive episode in a vulnerable individual. Ginny's diagnosis was discussed. They had a conversation, she and her family doctor, about major depression. They had at least some conversation about treatment options and the importance of commencing treatment. And we know that treatment early in the course of an illness like major depression is critical to recovery and the avoidance of complications. And you'll see here that as the duration of untreated illness increases, the likelihood of having recurrent major depression or severe major depression or a major depression that ends in death increases. So if you're having a discussion with Ginny, as her family doctor did, about what antidepressants could be used in treatment, well, there's a variety. Serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors. There's a mirtazapine, which is considered a noradrenergic and specific serotonergic antidepressant. There are serotonin modulators such as nifazodone and trazodone. There are dopamine norepinephrine reuptake inhibitors such as bupropion, and bupropion exists in sustained and extended release formulations. How do you choose between one class of antidepressant and another for the treatment of any particular person's major depressive disorder? Well, the meta-analyses of studies looking at the superiority, or at least potential superiority, of an antidepressant in the SSRI class over an SNRI antidepressant basically says there's not a whole lot of difference. In this particular meta-analysis that you're looking at, the relative risk favoring an SNRI over an SRI actually only 1.05, not a great advantage to choosing an SNRI. There are older agents that those of us who've been practicing a while remember. The tricyclic antidepressants, which have been used for a number of years, very good antidepressants, excellent antidepressants, in fact, in terms of efficacy, but dangerous in overdose. The monoamine oxidase inhibitors are effective antidepressants, but come with restrictions around foods that you can eat while you're being treated with an immunoinhibitor or medications that you can take while being treated with an immunoinhibitor. So the selection of an antidepressant really is not so much about efficacy, it's about safety, tolerability, drug-drug interactions, patient preference, other things that you'll want to have a discussion about. In the past, 30 years ago, when I first began treating patients actively with major depressive disorder, the general rule was start a patient on an antidepressant, see them back in 4 to 8 weeks. That's really sort of passing by as a general recommendation because studies such as the one you're looking at now suggest that you can tell who are going to be the responders, at least, in any drug trial within the first 2 or 3 weeks of the trial. About 25% of patients will show as non-responders, and they'll show early as not responding to anything. The other 75% will show either placebo response or response to the actual active antidepressant. But the whole pattern of this early sort of identifying of responder versus non-responder has led to the recommendation of sort of a rapid cycle of seeing the patient to make sure that you can tell early on whether the patient is responding or not responding so that you can act early in the course of therapy. There are psychotherapeutic approaches. Mild to moderate depression certainly respond to psychotherapies just as well as to medications, and there are a number of different psychotherapies that have been proven useful in the treatment of major depressive disorder, various cognitive behavioral therapies, interpersonal therapies that focus on role conflict and role transition, problem-solving therapies. So Ginny's family doctor prescribed sertraline, an SSRI, a very reasonable antidepressant, but really, based on Ginny's report, didn't go into detail about what to expect, how long it would take, what the dose range would be. Ginny felt a little nonplussed by her interaction in her first attempt, and she will admit that she may not have been the most engaged and active patient during that treatment attempt because she was feeling horrible and she might have been distracted during the visit with the doctor. So it just was a difficult interaction, but she felt like she didn't have and it wasn't given all of the tools that she might have needed to get completely well. The maximum dose of sertraline that was used was 50 milligrams a day, which is not nearly enough medication to get most people into the robust, sustained remissions that are necessary to extinguish depression symptoms and to maximize opportunities for recovery. So she took the sertraline for about 8 weeks, stopped it. It wasn't particularly working for her. When I talked to her about her impressions of the antidepressant, she said, well, I don't really think it happened, or really don't think it worked at all. And she didn't follow up with her family doc until months later. Ginny's second episode of major depression, a few years later at age 32, symptomatology very, very similar, difficulty concentrating, difficulty with fatigue, but underneath the concentration and fatigue, sadness, unremitting sadness. Nothing makes her happy. She's not motivated to do anything. She's falling out of social activity. She's not interacting with friends or family members. All of the symptoms of major depression that you might expect for her to have. And this actually raises important questions about what symptoms often persist even when the treatment of major depression is attempted but falls short of goal. Symptoms that fail to fully remit basically predict your next episode of depression or predict the fact that you're not going to functionally recover in the way that you could if you had a better quality treatment. If we're going to treat for major depression, we want to treat for a very robust target of extinguishing all of the symptoms that often persist at the exit of studies, even in people who are responding to antidepressants during trials. Insomnia, core symptoms like depressed mood, concentration difficulties, low energy, oversleeping, restlessness. So on the second episode, Ginny's doctor prescribes bupropion in an extended or sustained release dose, and it's 300 milligrams a day at maximum, which is a reasonable dose of bupropion. You can go all the way to 450 within label directions if you want to. She stayed on the medication for 12 weeks. She also got cognitive therapy from a psychotherapist. And in reviewing this second episode of treatment of major depression, Ginny said, it worked. I'm not sure what worked. I can't tell whether the medication worked or whether the psychotherapy worked, but I did feel better. So combinations of treatments, medicine, psychotherapy are very, very important. So 18 months ago, Ginny relocates near Greensboro, in the Greensboro area, actually into a neighborhood near my practice. And in that relocation, and the stress of that relocation and being off of medication and not connected with the psychotherapist, she begins to have the same symptoms. It's a very reproducible illness for her. Fatigue, concentration difficulties, sleep difficulties, sadness, lack of motivation. Nothing makes me interested. I've got tons of things to do. I need to get my kids into school. I've got new relationships that I need to be forming at work, at home, at church, at community organizations, and I have no desire and no motivation to do that. She has associated anxious symptoms with this major depression, also very, very common. And before we went through a full assessment of her depression symptoms, I asked her for some additional information. You know already that she's had 2 pregnancies and carried both to term, and they were both C-section births. Her BMI is 28, a little overweight. She's normotensive. She drinks about 2 glasses of wine per week. She smokes socially. I have a lot of women in my practice who smoke socially, 3 to 4 cigarettes a week when they're drinking alcohol in social settings, and that's Ginny's experience. I administered the PHQ-9. The PHQ-9 is a patient health questionnaire, 9-question version. It's a well-validated metric to measure and assess depression symptoms and also to follow improvement in depression symptoms over time. I'm a family physician. I would never treat your hypertension without measuring your blood pressure. I would never treat your diabetes without measuring hemoglobin A1C or glucose or self-monitored glucose. I mean, we're going to measure so we know when we're at goal. I never treat depression anymore without measuring depression, and we use the PHQ-9 in our practice to actually do that measuring. So Ginny's total PHQ-9 score was 19. She scored 3s, which is bothered nearly every day by depressed mood, lack of motivation, lack of energy, difficulty concentrating. The severity question for the PHQ-9 indicated that the symptoms were impairing her function at home, at work, in social settings. She had a major depressive episode, again, her 3rd one. We also did a G87. It's a generalized anxiety disorder scoring form. We're looking for associated anxious symptoms that often tag along with depression. She scored 14 on the G87, again, a score of 2 in every category of symptom, indicating that anxious symptoms of various kinds had been bothering her more than half the days in the last 2 weeks. We screened Ginny for bipolar disorder. Very, very important, because bipolar disorder, although requiring a hypomanic or manic episode to be diagnosed as bipolar disorder is lived as a depressive illness, and we want to make sure that we're not treating Ginny's depression as a bipolar depression with the wrong treatment strategies. So the CD3.0, which is the bipolar screener, was negative. The mood disorder questionnaire, another bipolar disorder screener, was negative. I actually asked her about some of her cognitive symptoms using the ASRS, which is a screener for adult ADHD. Now, she doesn't have ADHD by history. She certainly didn't have these difficulties with concentration and mental focus before the age of 12, but just as an idea or a way to get a sense of the concentration difficulties she was dealing with, I gave her the ASRS, and it clearly showed she was having various areas of difficulty focus, organizing, remembering, getting things done, tasks getting done to completion, a lot of symptoms that you might associate with ADHD. We screened her for substance abuse using the Audit C. Her alcohol use, only about 3 glasses of wine a week, and not causing a problem. We did some lab work. She's euthyroid, very important to know. Her hemoglobin A1C is 5.9, which is 1 point into the pre-diabetic range. And when we got our fasting lipid panel, the comprehensive metabolic panel was normal. Mild elevations in triglycerides, which do point in the same direction as the mild elevation in hemoglobin A1C. So Ginny's one of those persons that you might want to recommend a walking program and a nutritionist visit, and losing 5 to 10 pounds and then remeasuring these metabolic indices in 6 or 9 months or so. So we talked about the results of the assessments with Ginny. I recommended treatment, but Ginny pushed back a little bit. She was a little apprehensive about treatment based on her previous 2 attempts, and she was concerned, as I mentioned before, that her first provider didn't actively follow up. The second attempt at treatment seemed to work fairly well, but she only stuck with it about 3 months. But in no case did her provider seem to be actively engaged as a partner with her and getting her all the way to the treatment result that she needed, which is, as I said, robust, sustained remission. The treatment of major depressive disorder is a collaborative effort. Physicians, other providers, nurse practitioners, physician's assistants, anybody who's involved needs to be in an active collaboration with the patient. And it's very important to make sure that the patient's concerns are discovered and honored very early in treatment. We call that, in the area of motivational interviewing, a search for or an attempt at accurate empathy. Wanting to know what the patient wants out of treatment. So that engagement and collaborative conversation is one of the ways that we improve therapeutic alliance. And in that process of being an active participant in choosing and following through with treatment, Ginny's more adherent, more interested, more likely to make follow-up appointments. You are treating her in ways that she can sign on to immediately, and the results you're going to get are more likely going to be positive results. A couple of studies looking at the power of you in the interaction with a patient like Ginny in a therapeutic response. And what you see is that that very first moment in the room with someone like Ginny, where you are searching for collaboration, you are attentive to and interested in her agenda and her life, actually improves or increases the chance that she gets well. So Ginny had been on a couple of different antidepressants in the past, and since her last treatment, there had been several other antidepressants that had come on the market that I wanted her to know about. So we had a conversation about her antidepressant options. One of the newer antidepressants that had come out since she was last treated is Vortioxetine, which is a serotonin reuptake inhibitor, but with additional serotonin receptor modulating ability or capacity outside of the reuptake inhibition of serotonin. Very well evidenced effective treatment for adults with major depressive disorder. In addition to that, and kind of interesting based on her history, studies support vortioxetine's value in improving executive function in addition to the improvements you might get just from the antidepressant effect. So it looks like, based on several studies, including the one you're seeing here, like vortioxetine has a specific benefit over and above its antidepressant benefit in improving cognitive function in adults. One of the other newer antidepressants that's out there is levominacipran. It is a serotonin norepinephrine reuptake inhibitor that's a little heavier on the norepinephrine reuptake than other SNRIs in the past. Certainly a reasonable antidepressant to use, dosing about 80 to 120 milligrams a day. And then there's Vilazodone, which is a serotonin reuptake inhibitor plus it's a partial agonist at 5-HT1A with the target dose about 40 milligrams a day. Also approved by the FDA for the treatment of adults with major depressive disorder. So we talked about Ginny's options, and we landed on escitalopram as the antidepressant that she wanted to use. And we started at the starting dose, 10 milligrams a day. I did give her a small prescription for alprazolam to use as needed for sleep or for bothersome anxiety symptoms. I emphasized that this was a short-term strategy for short-term relief while the antidepressant began to work for her, and that we expected that the antidepressant plus the cognitive behavioral therapy she was participating in would likely make the alprazolam unnecessary over time. So she came back in about 4 weeks later. Her PHQ-9 remeasured, went from 19 to 14. She was tolerating the medicine well. So based on her recent assessment of symptoms, we increased the dose of her escitalopram to 20 milligrams a day. She indicated she'd only taken about 15 of the alprazolam tablets. She could continue to do that. We followed up about 2 weeks in phone conversation. She felt like she might be a little better. We scheduled an office visit for 2 more weeks so I could see and we could remeasure the PHQ-9 and talk about options. So Ginny's back in my office, and she's now 3 months into treatment of this third episode of major depression for her. She's been on 20 milligrams of escitalopram, which is the maximum dose, recommended dose for that medication. And we remeasure her PHQ-9, and it's still 14. And she still has significant core depressive symptoms in terms of depressed mood and anhedonia, and her anxiety is not a lot better. So now we have to have a conversation about what can you do when the antidepressant is at full dose and you've had plenty of time to at least begin to respond to it, and you're stuck at something less than full remission. Well, one option that's often discussed and used is switching from one antidepressant to another. So in this meta-analysis, we're looking at switches from SRIs, such as the one she's on, escitalopram, to an SNRI or to bupropion. And the result and the conclusion of this meta-analysis of studies is there's a small favorability to switching across to a different class of antidepressant. But look at the number needed to treat, 22. One recent strategy that's been well utilized, and there are a number of agents that can be used, is to use adjunctive atypical antipsychotics with antidepressants to move people from partial remission into remission. And this is a meta-analysis of 10 randomized controlled trials with various atypical antipsychotics that have been used. And you'll notice that the strategy of augmenting antidepressants with atypical antipsychotics of various kinds, quetiapine, risperidone, and olanzapine, those studies show a significant improvement. Here is a study that looked at aripiprazole augmentation versus antidepressant switching for patients with major depressive disorder. And in the blue bars, you'll notice that people who switched from one antidepressant to another really didn't make substantial gains over the 6 weeks of the study. Contrast that to people who had aripiprazole added to the antidepressant they were originally on at entry to the study, and you can see that the addition or the adjunctive use of aripiprazole seems to be a very strong strategy in this particular study. I mentioned before that there are several atypical antipsychotics that can be used in adjunctive strategies for the treatment of major depressive disorder. Brexpiprazole is the newest addition to that list. You have in front of you data showing the results of some of the registration trials for Brexpiprazole. Your target dose, about 2 milligrams a day, usually starting at a half a milligram, then going to 1 milligram and 2 milligrams. But again, very reasonable FDA-approved strategy for adjunctive treatment of major depressive disorder with an antidepressant. Here's a comparison again of a couple of other augmentation strategies. We talked about lithium augmentation earlier. Lithium augmentation was compared with triiodothyronine augmentation in the STAR-D trials, and with some benefit, about 30% of individuals getting to remission. The dose of lithium in the STAR-D trials was limited to 900 milligrams a day. The dosing of triiodothyronine was 25 to 50 micrograms a day, and the thyroid strategy was better tolerated than the lithium strategy, but that's an option and evidence-based. L-methylfolate also has been used. It's an activated form of folic acid and available by prescription and over-the-counter, has been used to augment or in adjunctive use for antidepressants. In smaller studies, the dose you'd want to think about would be 15 milligrams a day. And also SAMe, S-adenosylmethionine, which is a methylating agent, has been used. The dose in this particular study, 800 milligrams twice daily in addition to the antidepressant. Kind of a pricey strategy and not extensively evidenced by multiple studies, but an option that is at least evidence-based, certainly not approved by the FDA, but in terms of looking at the world of augmentation strategies, it's on the list. So we have a decision to make. Ginny's not doing well. We have multiple options that we could use to help her feel better. So we want the decision to be a shared treatment decision. So we had a conversation about potential treatment strategies. And one of the things that I discussed with Ginny was that the idea of switching from one antidepressant to another not only is only modestly beneficial in some studies, even in across-class switches, there's some time and some hassle involved. Going up on the dose of the second antidepressant and down on the dose of the first antidepressant, we call that cross-titration, might involve some adverse effects, it might require 2 to 3 weeks to accomplish. Ginny had a strong sense that she wanted to move this along as quickly as possible. And as we talked about the augmentation strategies and the likelihood that augmentation strategies were more rapidly effective, that really was something that she could buy into. So we ended up adding aripiprazole in an augmentation or adjunctive way to the escitalopram. 2 weeks later, after the addition of the aripiprazole, her PHQ-9 had already decreased to 7. So again, that very rapid, yes, we're moving in the right direction to reinforce the therapy. She's very happy with that. Even her GAD-7 score was diminished. I continue to follow up with Ginny regularly, and I'm happy to report that Ginny actually met a very, very robust definition of remission of her major depression about 4 weeks after beginning the adjunctive aripiprazole in addition to her base antidepressant escitalopram. I see Ginny every few months to confirm that she continues to be in remission. She is on maintenance therapy and wants never to have another major depression again, so she wants to stay on the medicines in an attempt to stay well. And that means the need for me and she to monitor for adverse effects. Atypical antipsychotics can have adverse metabolic effects. We certainly are measuring her metabolic parameters, a fasting lipid panel, a fasting comprehensive panel, and hemoglobin A1C. We talk about the importance of remaining adherent to the treatment plan. Ginny's story highlights a number of different things that we would consider when managing patients with major depression. First of all, a very high quality remission is necessary in order to achieve normal functional status and stay well for any particular time. Any residual symptoms that are present after treatment is completed really are just attributable risk factors or predictors of a relapse into the next episode of depression. We have a variety of treatments for major depression now, but antidepressants, although very useful, are of limited usefulness for many patients. And so to treat major depression aggressively, effectively, and into this high-grade remitted status requires additional strategies very often to make sure patients get completely well. And those strategies might be switch strategies, augmentation strategies, combination strategies of medicine and psychotherapy. The other thing I hope we emphasized as we discussed Ginny's case today is using a validated instrument to measure depression really can assist you as a clinician in tracking where the patient is in terms of their symptomatic status.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/RKM. This activity is supported by an educational grant from Takeda Pharmaceuticals USA Incorporated.